the people who are viewing this from afar. David Seltz, the Executive Director of HPC, and myself, Undersecretary for Health for Massachusetts, are very excited to welcome you to our first Primary Care Access Delivery and Payment Task Force Workforce Work Group. So that's that's a mouthful. And these are, like we've mentioned before, these are issues that are salient to everyone in our state. And so people are watching us very carefully to see what we'll be doing. David and I were very pleased to get a big shout out from the governor yesterday during her remarks at the Health Equity Summit, further underlining the charge that is laid upon us. So David, you want to take it over?
Sure. Good morning, everyone, and welcome to this first meeting of the Workforce Work Group, which I will stumble over every third time I have to say that, I will admit. We're really pleased to be able to have some dedicated time with all of you to dive a little bit deeper on some of the issues that are before the task force. One of the main deliverables of this task force is focused on workforce issues. And there is just so much we feel of importance to really be able to examine and understand and to be able to make really actionable policy recommendations that we ask members to self-select into one of two work groups. The first being the Data and Research Work Group, which met earlier this month, as well as this Workforce Work Group. So thank you for volunteering your time to this discussion. I do believe this will be one of many conversations that we're going to be having over the course of the next, let's say, 6 to 8 months, as we think about really being able to put together recommendations that will have the potential to really improve the delivery of primary care, the experience of delivering primary care, and really be able to enhance our workforce at the same time. As Dr. Mahania said, we were both at the Health Equity Summit yesterday, as I think many of you on this Zoom call were, and I just came away so energized and enthusiastic about the charge of this task force and the opportunity that we have here to really not only transform primary care in Massachusetts, but to really be a national leader. I think Dr. Critchlow talked about a primary care moonshot. And I think that is where we should be having our ambitions here, is to really be thinking about transformative change because it is so urgent and it is so needed. We have a great agenda for you today. We're going to be doing a little bit of laying the groundwork on what we know about the workforce here in Massachusetts, but really going to spend the bulk of our time leaving this open for discussion from all of you. With that, I'll turn it back over to my co-chair.
Thank you, David. So to do just quick introductions, we all know each other, but there may be members of the public who do not know. So I'll ask you to not do what David and I did, which is like to add comments. If you could just say your name and the title that is most relevant to your appointment to this commission, that'd be great. There'll be many, many more opportunities for grandstanding and point making in the future. So if we could just go and we'll start with, and I'll call your name and you could just tell. So Wayne.
Hi, the chair of family medicine at Tufts, family physician in Arlington, and founder of MAPCAP, Massachusetts Primary Care Alliance for Patients.
Dr. Brenda Pring.
Hi, I am a pediatrician and president of the Massachusetts chapter of the American Academy of Pediatrics.
Dr. Laura Black.
Hi, I am the president of the Mass Coalition of Nurse Practitioners and a very active practicing family nurse practitioner.
And forgive me if I mess up the titles. I'm trying to guess what your title is from the letters that are behind your name. So Jennifer Blewett.
Hi, yes, good morning. Sorry, I'm just joining here. I just came from another patient. Do you want me to introduce myself or just say hi?
Name and the titles that are most relevant for your appointment to this commission.
Sure. Dr. Jennifer Blewett. I'm a licensed clinical social worker at Massachusetts General Hospital. I work in addiction psychiatry. I'm also on the board of the NASW for the state of Massachusetts.
Thank you. Allison Bracken.
Hi, I'm Allison Bracken. I'm a physician assistant, and I work currently at Brigham and Women's Hospital and also representing the Mass Association for Physician Assistants.
Dr. Renee Critchlow.
Hello, everybody. Renee Critchlow, Family Medicine, Chief Medical Officer at Codman Square Community Health Center, and I am the Mass League of Community Health Centers represented to this task force.
Dr. David Gilchrist. I think you're muted, David.
Good morning, everyone. My name is Dave Gilchrist. I am here representing the Massachusetts Academy of Family Physicians and also serve as the Executive Chair of Primary Care for Atrius Health and Reliant Medical Group.
Dr. Steve Martin.
Hi, good morning, everyone. I'm a professor at UMass Chan Medical School in Family Medicine and a family physician at the Berry Family Health Center in the rural behind me and representing a rural perspective. So thank you.
Christina.
Christina Severin, President and CEO, Community Care Cooperative.
And Dr. Spivak.
Thank you, Barbara Spivak. I'm here representing the Mass Medical Society, and I'm also actively practicing as a primary care doctor. Thank you.
Thank you so much, everybody, and particularly to the members of the Workforce Work Group. You're right, David, that is tricky. I want to thank you for your time and the passion that you're dedicating. It is my pleasure now to introduce Dr. Sasha Albert, who will be presenting some research that Health Policy Commission did earlier on this year. Dr. Albert is the Associate Director of Research and Cost Trends. And so her presentation will form sort of the launching pad from which we will have our discussion. Please take it away, Dr. Albert.
Thank you so much, Dr. Mahani, and thank you all so much for your time and attention this morning. So I'm pleased to be sharing a selection of findings from our report on primary care and the primary care workforce in Massachusetts from earlier this year, plus a few findings, more recent findings on primary care provider distribution in the Commonwealth. Next slide, please. So to start with, who provides primary care? The core clinicians who provide primary care in the U.S., as we are all familiar, are physicians, internists, family medicine physicians, pediatricians, as well as nurse practitioners and physician assistants, with other key roles including pharmacy, registered nurses, medical assistants, and many more. I want to note that NP and PA involvement as PCPs, of course, varies by state, depending on state scope of practice laws, and Massachusetts' scope of practice rules have changed a bit in recent years. Next slide, please. So primary care in the Commonwealth is provided by a variety of different types of organizations. Most prevalent are models including hospital-affiliated practices, practices that are part of non-hospital affiliated provider organizations, independent physician-owned practices, and of course, community health centers. While newer models include retail clinics, urgent cares, virtual first or virtual only models of care, and both newer concierge practices and private or hospital affiliated practices that are operating in the concierge model. So the key roles we examined for our study were primary care physicians, NPs, and PAs. And on the next slide, we see that the share of primary care providers who are NPs and PAs has increased over time. So we see primary care providers in Massachusetts broken out by physicians in the blue, NPs in the yellow, and PAs in the orange. And you can see that the share of primary care providers who were advanced practice providers grew from just over a quarter in 2018 to almost a third in 2022. Reflecting this increase, the next slide shows the share of primary care visits provided by NPs and PAs, as well as physicians. And we see that the share of visits provided by advanced practice providers has increased over time, both for Mass Health members, which we see on the left, and for commercially insured patients on the right. And just to say a little bit more about how we looked at the role of advanced practice providers here. This slide uses our claims data, which means we're able to reflect both visits billed directly to each type of provider, as well as visits that have incident to billing, where care provided by a non-physician is billed under a physician's ID. And we do this to try to reflect the full extent of primary care visits provided by NPs and PAs. So we have PAs in the orange, incident to billing in the light blue, and NPs in the yellow. And we can see by the growing share of each bar taken up by those three colors that primary care provision by advanced practice providers is becoming more common. This is looking at individual visits provided by each type of provider. So we're not looking at sort of how many visits each type of provider or each individual provider is providing. It's really more of a bird's eye view on when patients go for primary care, who they're likely to be seeing. Next, we looked at demographics. So this slide shows the age distribution of providers in office settings, which we use as a proxy for PCPs due to data limitations. And we see somewhat different age distributions among physicians, NPs, and PAs. Physicians working in office settings are older. 1 in 5 are age 65 or older, as shown in the greenish piece of the pie, while NPs and PAs are relatively young. A fifth of NPs and a third of PAs are under age 35, as shown in the dark blue. By race and ethnicity, in all three roles, we see an underrepresentation of Black and Hispanic clinicians relative to the population of Massachusetts. So we have the distribution of the Commonwealth's population on the left-hand side, which serves as a comparison for the demographics of each of our three provider types. And we see that Hispanic and Black clinicians of each type, as shown in the orange and the yellow, are underrepresented relative to the population of Massachusetts as a whole. So that's broadly who our primary care providers are in Massachusetts. So now we'll turn to some trends in the number and distribution of primary care providers in Massachusetts. So on the next slide, we see that while Massachusetts has a larger total number of physicians per capita than any other state, we actually have a relatively low share of our physician workforce in primary care. I know this graph is trying to do a lot at once, but it shows the total number of physicians per capita by state, and then the share who are primary care physicians are broken out in blue. So Massachusetts is all the way on the left, showing that we have the highest number of total physicians per capita. But if this graph were sorted by just the blue part of the bar, we would actually be fifth from the bottom on primary care physicians per capita, or rather the share who are primary care physicians. And this indicates that our health system really prioritizes specialty care, which is troublesome because research has found that a high ratio of PCPs to specialists is associated with a host of positive outcomes. Things like better health outcomes, fewer ED visits, fewer hospitalizations, and lower costs. The next graph, yes.
Sorry to interrupt. I'm just monitoring the chat. Can you say a little bit about the data source here and what we know about, are these physicians who are patient facing? Are they perhaps in other roles? How much of their time is in clinical care? What do we know from the data?
Oh, yes. Thank you very much. So this graph shows physicians who are providing patient care for at least 20 hours a week. And we excluded any who are not in direct patient care roles. The next slide actually gets into the division between primary care physicians who are providing direct patient care and those who have other roles, things like administration, research, that type of role. And we look at this to see the relative growth of both primary care physicians who are versus are not directly caring for patients, and then comparing to not the growth of non-primary care physicians in either type of role. And we see that the number of primary care physicians in Massachusetts who are directly caring for patients has barely increased since 2014, growing by just 2% over those 6 years. Employment of non-primary care physicians has grown by almost 13%, which means that primary care physicians who are directly caring for patients are making up a gradually declining share of our physicians in Massachusetts. We're also not getting very many new primary care physicians in Massachusetts. Oh, I'm sorry. I see the chat. Primary care specialists who are hospitalists. I'll have to get back to you on whether we were able to incorporate care setting into this graph. That's a very good point. Thank you. So the next slide looks at incoming primary care physicians. We're looking at the share of new physicians who are entering the primary care workforce in Massachusetts compared to the rest of the country. And in 2021, we were fourth from the bottom among states on the share of new physicians going into primary care, about 15% compared to the US average of close to 22%. Looking next at sort of how our primary care providers are distributed in Massachusetts, here we see that most primary care providers, including physicians, NPs, and PAs, are affiliated with large provider organizations. The pie chart shows that 72% of our primary care providers are affiliated with one of the 15 largest provider organizations. Those organizations are listed in the table on the left. And as you can see from this breakdown, just MGB and Beth Israel Lahey together account for 30% of where our primary care providers are affiliated. So a fair amount of consolidation into large organizations. Now looking at some results by geography. As one might expect, our primary care providers are not evenly distributed throughout the state. Boston has the greatest concentration of primary care providers per capita, with nearly 35 primary care providers of all types per 10,000 residents. In contrast to the Metro South region, which has the fewest at just over 8 primary care providers per 10,000 residents. This next map shows the share of primary care providers who are NPs or PAs by region. In about half of the regions we show on this map, a greater share of primary care providers are advanced practice providers than physicians. In particular, the Upper North Shore, where 61% of our primary care providers are NPs or PAs. We saw a few slides ago that over 70% of our primary care providers are affiliated with one of our largest provider organizations, but this also varies by region. That is, the share of primary care providers who are affiliated with one of these 15 organizations varies throughout the state. 82% of PCPs in the Boston area are affiliated with one of these orgs, compared to 35% on the Cape. So now moving from distribution to a few challenges. Our study highlighted 2 reasons that primary care has become a less desirable and sustainable field. Relatively low reimbursement that can make it hard for new graduates to choose primary care, hard to sustain small practices, and can limit practices' ability to hire and retain support staff. And the second is high administrative burden that can make the work of primary care unsustainable for providers, and it is a factor in burnout, reduction in patient care hours, and even leaving the field. And I want to highlight the second one a bit because it's so important on a day-to-day basis. So the next slide is very dense, so I'm just going to talk through sort of the highlights. Primary care providers have many responsibilities beyond caring for patients, face to face. Things like high-touch asynchronous messaging through the patient portal, electronic health records, prior authorization, quality measure reporting, all of which can require substantial work outside of regular working hours and can lead to burnout, job exit, and a cycle of sustainability issues where there are larger patient panels for remaining clinicians and then increased costs via high turnover. So just to highlight a few ways that this has been measured, we cite a Mass Medical Society survey finding that over 80% of physicians cite increased documentation requirements that are not necessarily related to clinical care as an aspect of job quality in need of improvement. And another study found that physicians participating in value-based contracts report an average of 57 distinct quality measures, including multiple measures for the same condition. On the next slide, we talk about how this can affect patient care as well as the quality of PCP's working conditions. For example, team-based care can benefit both patients and providers, but can be costly to set up and difficult to maintain if there's high turnover or inconsistent staffing. Physicians cite inadequate mental health access for patients and high staff turnover as challenges, for example. Likewise, physicians cite inadequate support for non-medical tasks as a driver of turnover and burnout. To quote a physician we spoke with, PCPs are, quote, being asked to do more than what we are literally able to do. And just to provide sort of a quantitative way that this has been measured, we cite a study finding that without adequate team-based care, providing primary care can take 27 hours of work per day, more than anyone is literally able to do. And other related challenges include the mismatch between the prevailing acute episodic way that care is paid for, incentivizing seeing as many patients as possible, and the longitudinal prevention and screening focused care that PCPs seek to provide, which requires spending as much time as needed with each individual patient. So this is what we wanted to share with you all today from last winter's primary care report. Hopefully this provides a useful background and a useful launch pad for today's conversation. I see that there have been some questions in the chat. I'm happy to discuss for a few minutes if that would be useful.
I think I'll pause there. I think that we could delve more into the data and try to make the problem prettier, but I think that we can just agree that there are not enough primary care clinicians, there's not enough access. The question is, what can we do for the workforce part of it? I don't want to get too distracted in terms of dissecting out exactly, what percentage of OBGYNs would judge to be providing primary care versus not versus, right? I think the goal of this work group is really to focus on the workforce challenges. So I'd like to sort of open it up for that. We're going to need, I think we would have some short-term recommendations that we have, as well as some longer term recommendations in terms of workforce development plans. And also, although the presentation was mostly focused on NPPA and physicians, there's also the whole question of the rest of the primary care team, which since the COVID epidemic has also suffered in terms of shortages. So medical assistants, nurses, receptionists, like there's this whole ecosystem that exists within our primary care practice. And so I think the questions, we're willing to go sort of where members want to go, but we really have to sort of an eye towards recommendations and what we think we can provide as options for the bigger task force to then endorse that and then move on. So David and I will try our best to moderate and keep things going. So David, who was first? I see 3 hands there.
We've got the hands coming. I would just add to your setup here. I think for today, we really want to try to identify those areas and those topics that we want to be able to examine further, dive deeper, that we think are ripe for further investigation in terms of policy recommendations. The charge of the task force, if we just go back one slide really quickly, talks about 3 different topical areas that are interlinked. One around short-term and long-term workforce development plans for the supply and distribution, developing recommendations around primary care team-based care, and recommendations to improve the working conditions. I would not say that we're limited to those 3 topics as we think about the interrelated workforce challenges here, but just to provide a little bit of a guideline in terms of what the statute has tasked us to look at. And so, as Kiame said, really hopeful to hear from you today. What areas should we prioritize as we think about these 3 pretty big topics in terms of the work of this work group over the next few months? So I think, Barbara, you are first on my screen in terms of having raised your hand, so I'll open it up to you.
Thank you. I think it's very interesting because I think I could speak for 20 minutes on each of these, but I think one of the immediate things that we need to think about is many of the ideas that we come up with end up defining the workforce challenge and put solutions in place that appropriately help federally funded health centers. But what we see when you look at the widespread distribution, that even in areas where we have a high ratio of primary care to patients, we still have access issues. And I think one of the issues is that we don't define who's working full-time or part-time. And as physicians are getting older, we do see that people are not working full-time. So how do we identify what the real number of clinicians are out there? But I think one of the things we should quickly think about is how do we redefine where there is primary care access issues and not limit it to federally funded health centers. So, for example, the loan forgiveness programs require that people work in federally funded health centers. But it would be really great if we could put in a program that would help physicians go into private practices, because private practices are having a very, very hard time rehiring primary care clinicians to help as the workforce gets older. So I think that's one very quick short-term thing we could think about. I think when you get to improving the working conditions of primary care clinicians, you really get into the minutia of our day-to-day life. And I think it probably is something that we should really have a session where we focus on just that and really think about some of the minutia that we deal with. Because I think there are fixes, but it would take us probably 2 hours to go through and identify just some of those things that we could change pretty quickly, and would probably be better done in a very discreet meeting. And I'm going to stop and let other people talk because I have 20 minutes of things to say, but I don't want to monopolize. Thank you.
Thank you, Barbara. And I would just add that this is exactly what we hope to hear from you all. Like, what should we spend, a future meeting, an hour and a half on, diving deep on, and as you said, going through kind of what is a day in the life and all of the pain points that exist, could be absolutely worthwhile of that deeper dive. So thank you for those comments. The one thing I'll just add really quickly, just in terms of access challenges, we showed earlier that there was a higher, per capita physicians per capita in the Boston region. But I'm also struck that there was a recent report that just came out that did surveys of wait times for family medicine appointments of major metropolitan areas. And Boston ranked the absolute worst out of all of the metropolitan areas that were surveyed. So I agree with your point that looking at per capita counts is not necessarily reflective of access challenges, but is mainly just to try to help us understand where is the distribution and what does that look like. Renee?
Thank you. And Barbara, I totally agree. David, what I would probably add, though, is that, it's all about patient access. The fact is, it is not a surprise to me that the wait time in Boston is the worst. The two largest healthcare systems in the state do not have family medicine residencies. They don't. And as for the graphic that I put in the chat, the fact is, when you have less than 10% of internal medicine going into primary care, when you have, it's generous to say 70% of peds going into primary care. It's not 70. And you have over 90% of family medicine entering in primary care and staying in primary care. So if we want to look at the root cause of lack of physician access in this state for primary care, it is concerning that the two largest healthcare systems do not, they hire family medicine docs. They're always saying they can't find primary care, but they don't have family medicine residencies as yet. I'm hoping that they've understood that they have both the resources and the capacity to have amazing family medicine residencies. What is the state able to do to help facilitate the understanding that if you are taking state money, you need to be providing resources for the state also. If you look at the training patterns of residencies in this state, 53% of residents trained in this state leave this state, meaning that Massachusetts Commonwealth members are basically training ground for subspecialists for the rest of the world. They're using our poor people to train subspecialists for the rest of the world, and they're not providing primary care physicians for our citizens. And I'm 100% in agreement that it shouldn't just be about getting primary care for the FQHCs, because primary care as a foundation, we are all aware that that as a foundation for our healthcare system in the state will make a cheaper, a less expensive, and more effective system for all of us. So who's going to be encouraging the big systems to participate in creating those pathways? The fact is we have quite a few primary care docs, but one of the biggest things that we run into is the administrative burden. We need primary care investment increase. I'm 100% with Barbara. We need to spend a lot of time talking about how getting team-based care into the mainstream of primary care in Massachusetts is got to be critical, because what I'm seeing from all of my clinicians, MDs, DOs, NPs, PAs, they'll roll out of school doing a full-time FTE, and then every year they cut back and back and back. And also what I see is the folks who think that NPs and PAs are going to solve all the problems is that once their loans are paid off, then they go and they practice in a subspecialty, making far more money than I can offer them in primary care. So I see one of the biggest burdens is the understanding that we need increased investment, bottom line, so that we can do team-based care. But foundationally, we have to embrace in this state the fact that right now there is serious prejudice against primary care being family medicine, and understanding foundationally that if you want physicians who do primary care, family medicine needs to be said in every sentence and every C-suite, and they need to stop pretending that it's going to come from somewhere else. I'm new here, so maybe you guys can tell me why family medicine is treated like something that is a whisper that shouldn't be brought up. Honestly, I'll say it. I've said it before and I'll say it again. I grew up in the South as a Black woman where people thought I was stupid and didn't belong there. Being a family medicine doc in Massachusetts is exactly like being a Black woman in the South. I'm done.
Thank you, Renee. And when you're talking about the state role, were you thinking of something like a state graduate medical exam type of program that would favor sort of primary care residencies?
No, I think about things like GME, teaching health centers, collaborating with the state and the larger health systems. And I look at that, I'm like, hey, that would immediately, teaching health centers, the money goes directly to the community health center for training primary care physicians. So the state setting up opportunities with GME around whether it's Medicaid GME or however they want to frame it, but teaching health centers that collaborate, these larger health systems supporting family medicine training in the FQHCs, which would expand the capacity for primary care in the entire state, because it would increase our production of family physicians who are the physicians who do primary care.
Thanks, Renee. And I'm guilty since I only do 6 hours of primary care a week now. I'm one of those who've been cutting down. Wayne? You're muted still.
Sorry, thank you. Also guilty, day and a half a week of primary care. I try and do lots of good other stuff. And before I get to my comments, a quick word to Renee, one and everybody else. One of our 3 primary care bills, sponsored by Greg Schwartz, features restoring Medicaid funding for GME. I believe we're one of 7 states in the country that does not do that, and that will help address some of what Renee was talking about. So a few years ago, I had a conversation with Dr. Greg Meyer, who used to run primary care at the MGB system. And he sent out an email to all his PCPs, hundreds of PCPs, saying, "Congratulations, everyone's getting a raise." And he was surprised to get an email response within 48 hours of over half the folks saying, "Keep your raise. I don't need the money. Just drop my hours the commensurate amount. I just need to sleep, dude." And so that taught him that for practicing PCPs, it's not the money really, it's the job. We have to fix the job. However, for medical students to choose primary care, you have to fix the pay and you have to fix the job. There's great data from a study done about 16 years ago that shows the percentage of medical students choosing family medicine that ebbs and flows over the years. And it also shows the ratio of the salaries, average family medicine salaries divided by the average specialty salaries. And as that gets to about 70%, people flock to family medicine. But we're at around 55% right now. But what was interesting about that data is as that ratio ebbed and flowed up and down, the percentage of students choosing primary care ebbed and flowed in parallel with that line, to which my colleague 15 years ago said to me in my kitchen, "Altman, it's about the money, stupid. If you want clinicians to choose primary care, you have to pay them more." So I think we need to fix the job and fix the pay. Regarding the pay, loan repayment is helpful. It's a very useful tool for community health centers to recruit people to come work there. So I'm in favor of loan repayment, but loan repayment is not an effective tool at influencing medical student choice for primary care. The data is clear. It does not work for that. We need to fix the pay and fix the job to do that. Regarding the job, there are 3 major pieces that all were addressed by Dr. Albert's presentation. One is the administrative burden. We need to decrease that, obviously. The second is we need to establish very robust teams and the funding to establish those robust teams within primary care. And my colleague and friend Renee Critchlow speaks far more articulately than I do about how you can increase the capacity of your current workforce by having robust teams in place. And then the third is switching from fee for service to a prospective monthly payment. That has a dramatic effect on the psychology of practicing primary care and the pajama time and inbox time that feels very toxic and painful to people. All of a sudden, you get 2 or 3 hours a day carved out for that time. It's part of your job. It's no longer a toxic. It's no longer pajama time. It's during your day. And so those 3 things need to be addressed. The last thing I'll say is we've been working at this for 6.5 years, our team, and we've put together legislation that we call Primary Care for You, or PC for You, which addresses every last bit of what I just said. It addresses all 20 minutes of Barbara's would-be comments if she were given 20 minutes, because Barbara's been on that team. Many of you have been on that team. And if and when given the opportunity, I'd be delighted to share more about this legislation, which I think addresses all of the things that we need to do to fix the job and fix the pay. Back to you, David.
Thank you, Dr. Altman. And you know, as I think about the charge of the task force, and you know, the task force language is specific around where do we set a spending target to increase the investment in primary care? How do we change the payment models? How do we change the working environments? So to me, you know, part of our charge here is pay more, pay differently, and support a change in the delivery of care through team-based care, reducing administrative burden. So I think those are all very well aligned with what the legislature has asked us to dig a little bit deeper on.
Right on.
Dr. Black?
Hi, I'm actually one of those rare people who's in the process of ramping up primary care delivery. So I went from being on the health plan side to doing consulting. And so now I'm actually working pretty much full time as a PCP and also on track to own the practice that I'm working at now. So I will be the owner of an independent NP-owned primary care practice by the fall. I'm going between sheer excitement and complete terror in this endeavor, and I'll tell you why. I've been running the models over and over and over again around what it's going to take to make this practice financially stable. And full disclosure, it cannot happen just in the way that we are working now. I can't see 30 patients a day like I have to do today, in order to keep the practice stable. However, that said, I do think there's opportunity to leverage on some existing channels of funding that will help to increase revenue. And one of them is to focus on something like care coordination. And I know that that's part of, I'm actually working and intend to stand up an ICMP program internal to the practice with the PCC program. And the reason why is that I'm not so sure it's about spending more money, but finding places where money may be misappropriated. What I mean by that is, full example, I ran care management for a couple of health plans with very large budgets. I'm going to be pretty transparent here. Very large budgets, paying health plan-based care managers, the same care managers that I can't get a hold of right now in my own office. We're doing that work ourselves. We are doing care coordination, filling out forms. And so really having that opportunity to, if we could just get paid for the work that we're already doing, get paid for that pajama time. I don't know if it's necessarily more money, but rather than, as I said, redistributing or reusing some of those dollars that are being used in other places. I also wanted to push an ad and just make sure that we're all mindful when it comes to residency programs, GME programs. Remember, there are $0 that go toward NP residency programs coming out of Medicare, nothing. So you'll hear a lot about this. So whatever we're thinking by way of having advanced training, residency programs, any investment that we want to make in continuing education, it's important to include all of the colleagues that are engaging in primary care and are taking care of patients. And again, just one other thing that I think there's a lot of opportunity to look at the policies and procedures that are being forced upon us by these health plans. Again, arbitrarily making changes in formularies that now require all of a sudden, last year I needed to get a PA for albuterol. This year I have to get a PA for a Ventolin inhaler. Okay, that kind of stuff is really time consuming. And not only is it not fair, of course, it's not fair to the provider by way of having to do the additional work, but it's really unfair to the patients who they're the ones that are saying, you're making me change. We all know Blue Cross Blue Shield, for example, switching over from Zepbound to Wegovy, where we know that Zepbound is actually a more effective medication. I have a lot of patients I'm working on having to do that and just transferring patients around their medications. Another huge one that I think is the change in networks that arbitrarily get made, and contracts are changing all the time, where one morning you wake up and say, I can no longer see my PCP. That's how we ended up getting a lot of patients here because of WellSense not being accepted at by UMass any longer. Tufts not accept, Tufts together, no, Tufts, their exchange program product no longer accepted by UMass. So we spend a ton of time just finding clinicians or finding specialists for our patients where their insurance will even be accepted. And again, how hard it is for that patient continuity of care when they're used to seeing a specialist or a primary care provider for years and years. And then suddenly they wake up and they have to find a new provider just because a discrepancy or two entities couldn't decide on a rate. So I'll leave it at that.
Thank you.
Dr.
David,
Mahoney,
any
can I just follow
comments?
up
Yeah.
really quickly on that? Laura, my understanding is it's not just that the health plans may arbitrarily, change the prior authorization rules or change network rules, but that's one problem. But then the fact that all of the health plans do that differently and are all the time arbitrarily changing things. As it's not just like one health plan doing that, it's multiple. Is that fair?
Well, yeah, and I mean, I've sat on that side too. It's all about looking at your PBM, looking about what your rebates are going to be for the following year. Okay, fine, we're going to save a little money if we go with one brand versus another. We switch types of, we will switch medications that are covered. They may be in the same class, but they're not covering the same exact medications any longer. And so, again, as much as it is painful to the provider, it really is so unfair to the patient, to that lack of stability and knowing that from year to year, the medications that they've been taking are going to change, and they're going to have to change, and it's completely out of their hands.
Yeah, I find that to be just so striking to think about, for one health plan, the brand name drug, could have, be preferred. And then for another health plan, that same brand name drug has a prior authorization on it. And maybe that's what the PBM has negotiated and what they
Yeah.
want to, put in terms of tiers. But for, from a patient perspective, um, these choices are being decided for me just by nature of who I'm employed by and what health plan they happen to have, and that changes. You mentioned something else that I did want to raise with this group, and if people want to speak to it in their comments, would be interested. You talked about starting and owning an independent practice, and as we showed in the data earlier, so many of our primary care workforce is affiliated with the major systems. As we think about our charge here in terms of this workforce work group, is there value in thinking about policy recommendations that would enable and support the continued viability of independent practice? I think that's part of what's embedded in some of these ideas, but there may be an opportunity to be a little bit more explicit in saying what can we do in terms of a policy recommendations from the state with that explicit goal in mind. And I'm curious what others would think about that. Or you are.
I'm
Well, I
going to
think,
say yes. It's just-
yeah, I mean, I would think actually, I have to say that larger institutions probably love somebody like my practice because they don't they don't have to have this quote unquote money losing practice, and still they get a ton of referrals from me for specialty care. So I think and there's just something special about an independent practice. There's a lot more. We meet our patients' needs where they are, and we just have a lot of flexibility. What I would have to say though, what types of policy would be helpful? Definitely, we need to have full policy insight into data sharing requirements from specialty care. So, for example, my experience is some institutions are very quick. They'll see this patient one day. I get a fax with their consult notes same day. Others, could have a patient literally in the hospital for 2 or 3 weeks and not hear anything or not know about that admission until I get a call from the patient saying, "Hey, I've been home for 2 weeks. I was admitted to the hospital 3 weeks ago." So, I think that that's something that would be really important, is to mandate, or just I'm not as sophisticated in understanding how the health information exchange, how the highway is working right now in Massachusetts, but really making sure that we've got adequate access to data sharing, especially when an independent primary care provider is referring out for specialty care.
Thank you.
Go, Christina.
Okay. Couple of comments and recommendations. One, Renee, it was generous of you in your comments to not call out Boston Medical Center's Boston campus's recent decision to prohibit family doctors from doing their job with regards to obstetric care on campus. So it's pretty beyond the pale. I think it deserves a shout out for being beyond the pale. On policy recommendations, I'll go there and then I'll go back to what I was originally raising my hand for. This is also may be considered fringe by some, yet what I would say, David, in response to your question about specific policy recommendations on this topic, in addition to other ideas I'm going to bring you now, I would say to deem inpatient providers employing primary care providers to be a conflict of interest and to prohibit it. Going back to the top on specific
Wait,
recommendations.
Christina, to prohibit who from hiring?
Systems involved primarily organized for the purpose of inpatient services to prohibit them from employing primary care providers because it is a conflict of interest. On the specific policy recommendations that were aligned with the first three bullets that were shown in the PowerPoint at the start of this conversation. One, to require that no provider, including FQHCs, be paid less than their Medicaid rates by commercial carriers. MGB would never put up with it. The BI should never put up with it. Health centers shouldn't have to put up with it. Two, to institute an entity in Massachusetts that can serve as a unified credentialing authority. So end to end, one authority that credentials a clinician in the Commonwealth of Massachusetts. And that clinician, when they are complete with that unified entity, is credentialed with every carrier doing business in Massachusetts, would really contract down intense administrative burden that is disproportionately borne by practices that take care of patients who have lower incomes, because there are less resources to throw at the terrible, terrible bureaucracy of health plan credentialing that adds no value to the healthcare system. Lastly, on payment systems, and this was mentioned yesterday at the Health Equity Compact's annual summit, to replicate what Mass Health has already brought to the market around prospective capitation involving advanced and integrated primary care services with monies through tier payments that are add-ons commensurate with how much a practice wants to take on practice innovation and the complement of who they have in clinic for primary care services, care coordination, behavioral health, urgent care, etc. Thank you.
David, any comments on that one?
No, thank you. I have been really intrigued by, as I've been talking to all of you and others around the Mass Health subcapitation program, as a potential model that we should be looking to, and how do we create an environment where it's not just one payer doing that, right? We need the commercial payers involved. We need to spread that across so that it's not just a portion of your patient panel that is kind of covered by that. Certainly for community health centers, a larger proportion are, but how do we get the commercial plans engaged in that type of prospective payment with different tier levels for the capacities and capabilities? I haven't asked him yet, but I do plan to ask Ryan Schwartz from Mass Health to present at our July full task force meeting to the full task force to share a little bit more about how they have developed that program and what models we might want to think are most salient that we want to bring forth into a larger market. So appreciate that. On the credentialing piece, I will admit I don't understand maybe the history of why each health plan feels like they have to do this. But I will educate myself a little bit more. I'm sure there's some historical reason, but I don't know that it makes sense in today's age, but maybe there's some policies to be thinking about there. And As you know, Christina, there are proposals that are being discussed around commercial reimbursement not being less than Medicaid for community health centers and others. But
they get discussed and then they get squashed when the bill tries to make it across the finish line into the governor's desk. So we need to.
Christina, you used to be you used to be closely related to health plans. Do you know what? Because I know that a few years ago there was actually a law or a bill or a statute passed where everybody had to sort of get this unified thing, but then it never actually became reality. Where, like, what do health plans have some kind of regulatory requirement to have their own credentialing? I know that you were in that field for a while.
Yeah. I mean, there are NCQA accreditation requirements that health plans need to meet that do have some standards around credentialing. However, I'm confident that there are ways that Massachusetts could set up an entity that was essentially the delegated authority for the health plan that would be permissible to NCQA. I think it would be worthwhile looking into what some other states have done on centralizing this and still allowing the commercial plans to meet their NCQA accreditation standards.
Probably what Borum is doing is very redundant with credentialing and could be utilized for that purpose.
Yeah. Medicaid also has a process. You could say that it's Medicaid, and if you're deemed credentialed for Medicaid, that you're eligible, you're deemed credentialed for every commercial carrier in the state.
Thank you. I will move to Brenda.
Hi, thank you. I have 5 quick points to make. As the pediatrician in the room, I want to thank you for having me here. And just to remind everybody, and I know there are a lot of people who also take care of kids. Children are not little adults. We do true prevention from birth, and just want to make sure that we always are looking through that lens also of including the children's healthcare is a little bit different from adult healthcare. I would say with the Mass chapter of the American Academy of Pediatrics, we actually, from a perspective of doing something in the long term / short term, we have a grant that we are looking at our pediatric workforce training programs and trying to encourage more of the pediatricians in training to go into primary care. And in Massachusetts, I think Dr. Critchlow's points were really salient for pediatrics as well, which is that we do train a lot of excellent pediatricians here in the Commonwealth, and many of them are going into specialty care. But for the ones that aren't, we would like to keep them in Massachusetts and figure out why they are picking this specialty care over primary care. And so we're working on that actively with a grant that we have from the National AAP. I just wanted to comment on the conditions. That one thing I think it's adding to, 2 things adding to the challenges for pediatricians overall. There's daily moral injury, which I know we can't help, but our bread and butter, what we do with the most prevention is immunizations. And so that is, our per workforce was already in trouble when this report came out, and before things sort of really drastically changed in January. And just this week, really, really dreadful changes to our immunization plans and our faith in what recommendations will be made, and whether or not we'll be able to offer the Vaccines for Children's program and other things in the Commonwealth. But that adds to just the moral injury and potential burnout for our pediatricians. What I would also say is that for pediatricians, this has been going on sort of longer term, as our scope of practice has increased in addition to the, pajama time, et cetera, is that we are having to do many fellowships in behavioral health because there's not enough behavioral health providers. So we have to take time out of our day to go learn how to really care well for depression and ADHD and other things that were not in our pediatrician training. I'm not saying that it shouldn't be within our scope, but it's more, and it takes more time, not just in the training, but in delivering that care. And that's just being added into our time slot. So we don't really have as much bandwidth to do that. And then my 4th point was, just reminding everyone that half of all children in Massachusetts are on, or a little less than half, are on Mass Health. And while there are some programs in Mass Health that have some pay parity to keep Medicaid payments with parity to Medicare, and here I'm hearing about lower than that, but the pay is not necessarily true across the board for the same codes for Medicare to Medicaid, and it's also not going directly to the people providing the treatment, so not to the clinicians, the physicians necessarily. States like Rhode Island, our neighbor, have passed this, and Georgia, they have this regulation where every the codes are the same, whether it's a pediatric patient or an adult patient for the same amount of work. What I would say is that leads to just a reminder that in pediatrics, we have the lowest pay, according to Boston Globe, the average pediatrician makes $165,000 a year in Commonwealth. I know that's a lot of money. We live in a high cost of living area, and we take out a lot of loans to go to med school, as we know, and then spend those years making very little money when we're in training. So I think that adds part to the challenges, is that, like we said, just not just the pay loan reimbursement, but it's a longer term problem for our workforce. So with that, I think I will stop and make my other point later if it's needed. Thank you.
Thank you so much for those points, David. I don't think I have anything to add to those comments.
I'll just ask one quick question. Brenda, you mentioned as one of your points the kind of increased kind of scope of practice, so to speak, in terms of the types of conditions that you're being asked to treat and care for, and you said, of course, we should do this, but it's just becoming more increasingly complex and thinking about mental health and other challenges. What would be something that would help you and other pediatricians in being able to adequately adapt and to care for? Is that about an expanded care team? Is that a reimbursement issue? Like, what would you think is in terms of a policy remedy?
Yeah. Thanks. I do think it's a good question that an expanded care team can help. There is a system where I practice at Atrius that does have more access to behavioral health with a sort of a partially integrated model. A true integrated model would be fantastic. But listen, it's already hard to get, mental health care, behavioral health care. In pediatrics, child health providers are even lower. There are a lot less of them. They go out, they have, they turn over quickly in some places and then go up and do their own practice. So we don't have necessarily any way to sort of build that in. And then obviously having a little bit more time, you can't sort of see a kid in 20 minutes who's got serious depression that you're trying to manage. It's not a really great, safe way to assess them. So I think all of the above, but I think there's workforce issues, and I know the Commonwealth has worked separately on the workforce in behavioral health, but it's trickling down. It's not just that, right? It just falls on the lap of the primary care provider.
Thank you.
Thanks. Barbara?
I want to just emphasize one of the points that Christina made, which is, I think that when we look at payment reform, one of the critical things that we're going to have to think about is there's a real problem when you look at the list of who employs primary care, and that the majority are academic medical centers where their prime interest is in getting highly remunerative procedures and filling hospital beds, not with medical patients, but with surgical patients that reimburse much better than medical patients. And that if we're really going to reform primary care, we need to rethink who is employing them and how is payment reform going to happen. And I think Christina is really implying, and we need to look at a whole new system where primary care is taken out of these academic medical systems, which I know is not going to make me popular in my own system to say that, because in fact, the system I work for is doing a lot to support primary care. But in general, we need much more of a team-based approach, much more of an investment. And I think that if it were not done by these big systems, we might have a better ability to really take the same amount of money and redefine it and repurpose it to give team-based care. because the work that we need in terms of case managers, social workers, pharmacists to back us up in primary care, we can do a lot to take care of some of the burdens that were already raised about prior auth. But there's much more that we can do to help our patients get better care that will also alleviate just some of the angst of primary care. And I think, so I just want to emphasize that when we get to payment reform, that may be one of those things we have to look at. Thank you.
So Barbara, you don't think that it'd be possible to design payment systems so that big academic medical centers like everybody else would be incentivized to promote primary care and prevention?
I think one would argue that those incentives are there now in a managed care world. And for many of you who know me for years, the organization I ran for 27 years, McIPA, was one of the original groups that went into managed care, value-based payments, both on the Medicare and the commercial side. And it really hasn't brought the changes that we need, and they haven't taken effect. And I look around the room and I see people saying, yes, that's true. We need much more support and investment in primary care. And I don't see that happening yet. And I've been involved in this for 27 years. And so I'm reluctant to say that I think we can do that without separating it.
We will
Thank
as part
you.
of this task force.
Thank you, Barbara. I'll go with Steve. Go ahead.
Hi, thanks so much, and I look forward to deepening each of the ideas that people have just expressed. I hope it's okay just to put forth some 30,000-foot ideas and 1-foot ideas, and know that we'll have to build on all these as we work together. One is that primary care is a scarce resource. And I presented recently with David and others at a Medicare gathering. And the slide that I put is that primary care is like the shed at the bottom of my garden. There's so much stuff in it right now, I don't even know what's there. And I need to build another shed to figure out what's in there. I think we haven't as a group or have consensus about what should primary care be doing, which would really affect how we think about workforce. So that is a non-trivial point, a pretty fundamental one. But given the 27 hours a day that I'm supposed to be doing and work, then clearly what we've done so far is not sustainable and never was. I think identifying what a good result would be for the workforce would be important. To me, the good result would be ongoing continuity that's predictable, accessible, that has capabilities that patients need. And I want to go back, thankfully, to Brenda's point about the kind of work that we're asked to do. The more complicated the work we do in primary care, the better it generally is for patients. And at the same time, the more time it requires for each of those patients. So we're going to have to square circles around what is actually valuable about primary care and the value that we add. And that value is often around things that we don't do very well now, which is mental health is right up there. Substance use is right up there. Long COVID is right up there. Complex medical care is right up there. We don't do those very well now because they don't fit in a 10 or 15-minute visit very well. I'd say that we should recognize that specialty care is also broken. It's about a 6-month wait to see endocrinology at UMass. It's about a year to see outpatient GI at UMass. It's about 6 months to see someone for new onset seizure at UMass. And those are not just UMass, believe me. I know that they're the same elsewhere in the Commonwealth, and even worse in rural settings. That means that I, as a primary care doctor, have to do a lot more deep work around things that I need to learn about and take care of, and until those visits can either happen, or so we need to rethink about what those pressures are providing as well. I would say I'm so grateful that and Wayne brought this to our attention. Look, I've been asked over the course of my career as a residency professor to be the happy preceptor. Being a happy preceptor to help encourage students to go into primary care is a losing proposition and always was. And we are more engaged in something that is a barn raising, that is we're going to have to raise many different parts and improve many different parts at once for anything to be viable. Because just asking people to go into primary care is not going to be a good outcome when primary care is not doable. So I think recognizing that in the committee and task force certainly has. So more specifically, our education and training programs are broken when it comes to primary care. I mentioned in the chat, I'm one of 5 family medicine graduates in my class from Harvard. That's absurd. We need to renew and reestablish, actually develop an entirely new social contract with our health profession schools that are now accepting patients. As the admissions process are really based on the research in biochemistry that students are doing. And I love biochemistry. I don't use biochemistry virtually any day of the week with patients. And I used to teach science and love it. So we really have to get underneath the hood as to what the heck is happening with admissions and tuitions and loan repayment. And the only reason I'm in primary care, not the only reason, but I was a National Health Service Care Scholar, which pays the tuition up front. And we're never going to get this as a loan repayment prospect, as has been alluded to already. And the last thing around teams, I've had the good fortune of working with my sister-in-law in a primary care team and love working with others in a team. Primary care teams are not very well defined in the literature. They're not very well defined in policy. And they are sort of a little bit of a yard sale. They're sort of like, who could we hire? How did they get here? What are they interested in? But these roles are really ill-defined. This is not like the Celtics. Like, there's no general manager, there's no coach, there's no training program, there's no spring training for the Red Sox. We have almost no training for outpatient teams at UMass. And I think it's the same elsewhere. So this idea that we have in our heads of teams is like a sports team, but that is not what the work looks like. It takes a lot of work to make a team work. And we, I think, are being too shallow about what that team actually requires to do and how it could actually help patients. And lastly, I think that we could expand our idea of actually who is on that team by really thinking about our colleagues in public health. We could really think about community health coordinators and workers, town nurses, people who are experts in social determinants of health. So I'm not working on housing at the ground level to try to help someone. Other people are much better at it, but I don't know who those people are. So I hope that gives you a sense of sort of like the day-to-day work, but also that some of the solutions that we may think are at the ready aren't quite something we know as much about as I wish we did. Lastly, we need to reduce patient panels. The market's already speaking. People going into direct primary care are doing that to reduce their panel so they can take better care of people. And that puts us in a problem because when we reduce panels, we leave more people without care. But we are going to have to really, I think, as a task force, wrestle with this. A panel of 2,500 people, which has been the standard, is ridiculous. And either you're taking care of 2,500 completely healthy people you never need to see, or you're just hoping no one gets sick. I mean, it's just a terrible way to think about the work that we do. And we have to be honest about what each clinician is capable of doing. Thank you very much.
Yeah, thank you, Steve. I mean, one of the things that struck me, you're talking about teams and systems. I was always surprised when I saw patients that had predictable things that they needed and that I was supposed to talk to them about it. Like I always thought, oh, why am I coordinating the mammography? Why is that not happening? All the things that we can predict, why is there not some better system than me finding the time in my 12-minute interaction to talk with them? So that was good. I mean, you brought in a lot of challenging ideas. David, do you have sort of follow-up questions for Stephen?
No, thank you, Dr. Martin. And I think I agree with you. Part of our challenge here is the need to improve many things at once, that there isn't going to be one lever that we can press on that's going to solve this workforce challenge writ large, right? And so it is, and I think even the charge of the task force in this work group, I think, reflects thinking about education and training, thinking about the care delivery, thinking about administrative burden, thinking about what do we want primary care to do as a fundamental question. And I do think as we continue this work of this work group, I do think it would be valuable for us to continue to articulate, what is our vision for our goal? Like what do we want to accomplish? What are the values that we want to try to say? This is what we're these policy recommendations will lead to. It will lead to bringing joy back into primary care. Whatever that is, I think could be helpful as we continue this work to articulate kind of an endpoint that we're working towards. So I do think, and I want to make sure we have time for everyone to be able to speak here. But one of the questions I'm going to ask at the end here is, which one of these kind of buckets do we want to tackle at our next work group meeting, which we're hoping to do in July before August. And so think about that. But we'll turn it back over to you, Cami.
Okay, Dr. Gilchrist, and then Allison Bracken. Did we lose Dr. Gilchrist? I think he probably tried to unmute himself, and instead he clicked out. There, I see him back. So all you, Dr. Gilchrist, it's all yours. Well, Allison, why don't you go ahead while we try to resolve Dr. Gilchrist's technical issues there.
Sure, thanks. Just a couple of quick points. I think that the loan repayment is great, especially being a PA. Our loans are pretty high, not as high as medical students, but coming out, we're certainly, our salaries are much lower. So I think that was a great point to bring up. I did want to also talk about like the team-based. I mean, we try to do some and I know it's not well defined for sure, but some team-based with like PA teaming with an MD, and we've had a lot of issues with physicians leaving. And then there's a huge panel of patients that we're trying to scramble and figure out. And so PAs don't have full practice authority in Massachusetts, and we can certainly take over a panel, but we also then have to find a new supervising physician to work with, and that can be problematic. And then where those patients go, and then that supervising physician already has a full panel, and are they going to be somewhat responsible for the panel that the PA may take over, from the physician that left. So I think there's all of those issues that are somewhat, could be solved, and then PAs could own a panel without having to be tied to a physician. Certainly we want to collaborate, and we're happy to work with the physicians and know our limitations, but I think that would open up a lot of access, and we wouldn't have to turf patients to other physicians or try to scramble to find one. We have so many patients that, once a physician leaves, they're kind of left without a primary care doctor. And we have great PAs that could take over some of that care, but there are some limitations. So I just wanted to make that point.
Thank you. Yeah, the scope of practice issues are definitely one of the things we will need to come up with recommendations on. So it's good to bring it back up. Dr. Gilchrist, hopefully, we've resolved our technical issues.
Yeah, can you hear me okay?
Yes, we can. Thank you.
Okay. So lots of great points already. I wanted to circle back for one point on the credentialing piece. Credentialing is not just an administrative burden, it is an access issue. Most organizations will bring on a clinician, a physician, and they won't start seeing patients fully because they're not credentialed.
Did we lose him, or is it just me?
He froze.
We lost him,
Rose.
but he was making a great
with
point.
payers.
Yeah.
They limit
Making that-
alternative.
You're
That might be an
unfrozen now.
option to overcome this. Am I freezing?
You froze we heard the first 3 sentences, but we didn't hear the last 3.
I'm going to hold off. I'll put a comment in the chat. I'll try to figure
Okay.
this out for next time.
So David, before we go to Renee, because I know we're very close to closing time. So do you want to sort of put out a question out there in terms of the buckets, and then people can either raise their hands or put it in the chat, since we only have about 5 to 6 more minutes here left.
Sure. Yeah, absolutely. So just to give you all a little bit of information about the sequence of events here. So next week we're going to be meeting as a full task force, and as part of that meeting, we'll have a report out about this conversation that we've had today, as well as the conversation that happened at the Data and Research Work Group. We're also going to be joined by Chris Kohler from Milbank, who's going to be talking a little bit about the concept of setting primary care spending targets, how that's worked in other states, and some lessons learned. So we were looking forward to that full task force meeting next Tuesday. But we do want to really kind of keep the momentum going on this work. And I know that we're asking a lot of you in terms of your time and participation on this task force. But we do hope to have another work group meeting of this workforce work group in July, probably closer to the end of the July, and we'll be back out to talk about scheduling with all of you. I think a question that I have is how do we want to use that time? And I think we've raised so many big picture, detailed questions today. I guess I would propose that we could spend a full hour and a half really talking about the administrative burden issues and some of the very particular pain points that primary care providers face in their daily practice, going a little bit deeper on issues of the paperwork, the prior authorization, maybe spend a little bit more time. We can do some more research on the credentialing piece. But that seems to me to be a topic in and of itself. Although I could also, if you want to spend the time just focused on education and training, we could do that as well. So I raise those as issues, but maybe would propose really honing in on the admin burden and pain points in practice. But open to others' thoughts on that.
Let's go with Jennifer first, since she hasn't spoken at all yet.
I'll be very quick here because I know we only have so much time, but as the lone social worker in the room, I appreciate everyone sharing their perspectives and thoughts. Having a lack of primary care doctors is something that we've, as social workers, have felt for a very long time, especially in the state of Massachusetts, where we pride ourselves on really being a state of excellence when it comes to healthcare. But it has these profound and cascading impacts on social workers. It has the ability to increase workload, complexity of cases, emotional burden. There's an increased demand for social work services, and I have less social workers coming into the field than ever. Similar to primary care doctors, people come here and train, and we train them excellently, and then they leave. And so we have people who are social workers in the field trying to manage chronic conditions as clinicians, especially from a behavioral health care standpoint, when they can't get their needs met through primary care treatment. And it's really something that we're starting to see, not just increased burnout and burden, but the shortage of primary care doctors pushes kind of that further burden of addressing comprehensive patient needs further. And I just wanted to say how much I appreciate all the work that you guys do. And then hopefully we can get some changes made. So thank you.
Thank you, Jennifer. And I apologize for those who have their hands up because we won't be able to get to them given our limits of time. But I wanted to really thank people for the passion and clearly the decades of knowledge and expertise that you're bringing to your comments. And I'm hoping that your passion doesn't turn into frustration as the months go by. We're really hoping to harness that to make some really concrete recommendations. So, David, I'll let you bring us home.
Well, thank you, and encourage all of you to reach out to me or Dr. Mahania with any additional thoughts and thoughts about how we might want to structure our next workforce work group meeting. I thought this was just a fantastic conversation today, and I'll end where I began, which is I continue to be enthusiastic and energized about the potential opportunity that we all have here to make significant and important change. And I really appreciate all of your time and thoughts and passion, and look forward to our continued work together.
And when's our next meeting, David?
As I said, you can see the schedule here for the full task force meetings. The next week's meeting is going to be virtual. We do hope to bring you all back together in person one more time before August for a full task force meeting. That's going to be on Tuesday, July 22nd. And as I said, we hope to schedule a second these work group meetings before August, and so we'll be in touch on that. So thank you again.
Thank you so much, everybody, and see you next week.